The 6-minute walk test remains a cornerstone submaximal exercise test for objective functional assessment. Because it correlates well with peak VO2 and daily physical activities, it is highly practical for tracking disease progression and therapeutic response. Clinical utility in heart failure, routinely used to test baseline functional capacity correlating closely with NYHA class, track response to interventions like guideline directed medical therapy optimization or cardiac resynchronization therapy placement, and aid in prognosis. In pulmonary arterial hypertension, it is a mandatory component of risk stratification. It directly guides the escalation of pulmonary vasodilator therapies. In cardiac rehabilitation, the standard baseline and exit metric for quantifying functional gains post acute coronary syndrome, valve replacement, or coronary artery bypass grafting. Prognostic thresholds. Under 300 meters, it is strongly predictive of increased mortality and readmission in both heart failure and PAH. Over 450 meters generally indicates preserved submaximal functional capacity and a favorable prognosis. The minimum clinically important difference is typically 30 to 50 meters for most cardiac cohorts. If standardizing the test for clinic staff, the American Thoracic Society guidelines require strict adherence to the following. The track, a flat enclosed corridor exactly 30 meters in length marked with cones at the turnarounds. Pacing. The patient entirely sets the pace. Administrators should only use standardized encouragement phrases at 1-minute intervals, like "You are doing well, you have 4 minutes to go." Vitals. Pre and post-test BOG dyspnea and fatigue scores are required alongside resting and post-walk SpO2 and heart rate.